From the Chronicle Podcast Network, this is the Skin Spectrum Podcast, your weekly conversation about ethnodermatology. This discussion is all about our skin, the doctors who treat it, and the diverse patients who live their lives under it. On today's Skin Spectrum Podcast, we continue our summer series of weekly reports with a special focus on the Black dermatology patient. Our fourth episode of the Skin Spectrum Podcast Summer of Dialogue focuses on approaches for treating keloids. Continuing their conversation from last week, our guests for today are Dr. Yvette Miller-Monthrope, dermatologist, dermatopathologist, and assistant professor at the University of Toronto, and Dr. Vincent Richer, dermatologist and clinical assistant professor at the University of British Columbia. Here's their discussion.
Dr. Richer, I think maybe we could move on to keloids.
I think we're ready to switch gears here.
I think so. So in your practice, who are the most common individuals that you see with keloids?
Yeah, I would say that the typical patient with keloids is just otherwise young and healthy, right? So they're often, let's say, in their 20s or 30s. But although, we do see kids, and I did find a keloid on an 80-year-old the other day. But it's certainly overrepresented in young adults. And we see it more on Asian, brown, black skin. Definitely, it's going to occur over the ear area, and we see it over the shoulder girdle and sometimes also the pelvic girdle as well. The understanding is probably that there are some lateral traction forces on the skin that probably trigger our fibroblasts or scar cells to just keep on working. They're working overtime. So when I'm talking to my patients, I'm telling them, you're healing too well, right? We're just laying down too much of that collagen. That cell's a little bit in overdrive, and that's when we see these fibrous bumps that, not only are not super pleasing cosmetically for our patients, but can be extremely itchy and extremely painful as well. And so I audited my practice last year, and I see about 350 new keloid patients a year, which I think is a pretty decent amount. And we develop relationships because we keep seeing each other quite routinely for treatment. But people get better, and it's something that I really like treating in my practice.
I also see quite a lot of keloids in my practice as well in Toronto. And I agree with you. It can be so disfiguring. And even in some cases, it can lead to functional deficits, depending on where the keloid is. I had one patient with a keloid that was spanning over their antecubital fossa, and it was actually difficult for them to bend their arm. And so, when patients say, or people say, oh, it's just a scar, like it's more than a scar, because we know that they can tend to grow and outside of the area of where the trauma was, and it can cause a lot of problems. And so do you recommend anything that patients can do at home for keloids, or?
Yeah, there is a small amount of evidence to support wearing silicone patches. And by wearing silicone patches, I'm saying wearing them 20 hours a day, I think. And so it is thought that they will hydrate the scar. And so it can make it actually more pliable. There are some studies showing that it can actually reduce the height of a scar and even treat a bit of pain and itch that is often a bit of a presenting feature for those scars. Another interesting feature is that when patients wear this ahead of our scar injection treatments, the scar is usually softer at the time of injection. And so that's something that I do bring up, but it is a bit labor intensive to be sticking that on and sticking that off at home. And so, oftentimes when we do our treatments, it's to try and get our patients to rely less and less on those patches over time.
That's really interesting. I haven't been recommending these patches, but I think I might, because sometimes when you go to treat those keloids, they're so hard, and you have to use especially if you're using injections or something like that, you have to use like a larger bore needle because, it's just, they're so difficult to inject into. And so, that's actually, thank you for that. That's a tip that I might employ in my toolbox for treating keloids. So what is your approach in the office for treating keloids? I mean, you have a large practice of keloid patients. What's your typical approach?
The first thing, and I think we usually approach things that way, like for acne and hyperpigmentation, a lot of my patients, they have spontaneous, quote unquote, spontaneous keloids or from acne. And so I want to make sure that whatever's bringing that on, we have some level of control in the background. And sometimes that means putting them on isotretinoin or Accutane for a while to make sure that we treat the cause correctly. Scar injections are going to be the mainstay of treatment in my practice. It's a reimbursed service provincially here. We don't need to use any fancy devices to do it, and it does help quite a bit. You briefly touched on it, but probably injecting scars is one of the most unpleasant things that we do for our patients. And there is something about separating those collagen fibers with liquid. Even if it's lidocaine, it's very painful. And so that's something that I want to make sure that my patients are aware of. And the thing that I do tell them is the more we do it, the more we treat you, this is going to get less and less painful and more comfortable. So people do come back, I think, because our treatments do work. Yeah, historically, I think what's mostly being used is cortisone, so triamcinolone acetonide, and the concentration can be adjusted based on the location. But of course, the problem here is that it can also thin out or reduce the collagen of adjacent healthy skin. And so we can see atrophy and we can see hypopigmentation. And hypopigmentation is a big problem in a condition that is overrepresented in skin of color. But it's inexpensive, widely available, and it does help. So I think that's a lot of what we're doing. A few years ago, I had a patient who had a large burn keloid on the arm. She was actually constantly wearing a brace to create pressure there. She would never leave without that brace. And she had hypopigmentation and a bit of atrophy from injections. And I'd been at a few conferences and read some articles about using 5-fluorouracil, so an injectable chemotherapy agent that would be less associated with atrophy. And so I've actually integrated that into my practice, and I do a bit of a mix using the 5-fluorouracil and the triamcinolone acetonide together. Initially, I was doing that to cause less atrophy, but some papers and some meta-analysis came out showing that the recurrence rate over 6 months was probably lower using both of those agents. So I thought that was pretty interesting, because you probably experience, like me, that maybe 40 to 50% of people over a year, they can have some recurrence of a keloid.
Yeah, absolutely. I like that you're using the 5-FU with the triamcinolone acetonide. I haven't done that yet, but it's definitely something that I'm going to consider. I think, because these are so challenging. For very, very bad keloids, I mean, in the Sunnybrook Cancer Clinic, we've actually even had to treat some patients with radiation, or sometimes combinations of excising the keloid, which traditionally we never cut out keloids because it'll just grow back or get worse, but excising them or cutting them out with the help of a plastic surgeon and then injecting immediately or applying an agent such as topical 5-FU or imiquimod or something like that as well in combination. I haven't had a lot of experience in doing that, but I have done it a couple of times. The other thing that I found interesting, I don't know if you've had an opportunity to see this, but there's a lot of chatter, about people with widespread keloids and dupilumab. And it was found to be quite helpful in patients who have atopic dermatitis. So again, it's that repurposing of medications used for other things, and then in a newer thing. And I've heard that patients who have atopic dermatitis and are doing well in terms of their atopic dermatitis and are on dupilumab, which is the IL-4/13 inhibitor, have also saw shrinkage in their keloids. Have you heard that, or do you know anything about that?
Like you, I have seen some chatter in our scientific community. I haven't had the fortune of experiencing it in my own practice yet. Mm-hmm. It would be great if it wasn't such an expensive medication so that we could give it a try a little bit more seriously. It's certainly, interesting to observe. One thing I find hard with keloids, and you mentioned it, if there's no clear first-line treatment, it's because our treatments are not perfect. So we have to reach for all these things in our toolbox. We want to avoid surgeries, but if plastic surgeons reorient the tension lines, maybe that'll be good and it won't come back. We might add on radiation, those topicals. Because we use a lot of lasers out of our practice, there's something called laser-assisted drug delivery that's mostly I use for hypertrophic scars more so than keloids. This is the idea where we deliver fractionated ablative lasers. So we basically vaporize tiny little holes within a scar, and then we paint triamcinolone acetonide, we paint the cortisone lotion immediately on top and put it under occlusion. And so not only is the ablative laser training those fibroblasts to relax a little bit, and it's also making the scar less stiff, we are delivering through those small channels those medications. And so certainly in plastic surgeons that take care within burn wards or of veterans that have burn scars, they are using that more and more to restore function to people. So it's an interesting and sexy repurposing of our devices to try to treat this condition.
Sounds incredible. And I look forward to sort of seeing that probably happening more in the future as we get to know more about this new method. And certainly I'll be sending over to my laser colleagues. I wish you were here in the GTA, Dr. Richer. But we have
great colleagues over there.
Great colleagues in the Toronto area as well, who certainly I could partner with, help with that. So I guess that being said, I guess that will bring us to the conclusion, unless you have anything else to add about hyperpigmentation and or keloids?
Maybe one last thing would be to think about elective procedures in our young patients with skin of color, maybe over the ears or the shoulder girdle area. I have quite a few patients in my practice that had a small cyst removed up from the neck or a little mole by the bra line, and now we have to deal with this keloid, which is a much more problematic thing to deal with. And so certainly as dermatologists and healthcare practitioners, that's something we must keep in mind as a potential risk from small procedures in those areas.
I agree. And I think I briefly forgot to mention when we were talking about the ears, the pressure earrings, do you recommend those for your patients? I mean, there's an online store, you can get these pressure earrings. I'm not really sure if they work very well or if it's just giving the patient something to do. I'm just curious to know what you think about these.
I do talk about them. I find that the absence of an exit strategy out of that earring is kind of off-putting for people, right? We don't really know how long we have to use it. And so, you talk about how much we don't really like doing surgeries for keloids. When I'm treating keloids of the helix, I actually do quite a bit of laser surgery with close follow-up for injections. And I found that to be quite effective. Those large round keloids that are on the earlobe or on the helix, I found that at some point I kept injecting them and they become this sort of fleshy spot that, we sort of plateau and we're not necessarily happy with the response. So I've been doing more and more of either ablative laser or laser-assisted drug delivery to shrink them. I'm trying to free our patients from doing all these home responsibilities. But certainly, if people have had a huge surgery, they don't want to go back on any of that, and they want us to do everything we can to prevent that recurrence, I think that pressure earring would make sense.
Well, I guess that concludes our chat today. It's been so lovely speaking with you, Dr. Richer. I just really enjoyed it. I got a lot of tips that I probably will be taking forward into my own practice. I guess we should also thank all of you who are listening in today and just remind everybody that, if you have patients or if you are yourself struggling with keloids or hyperpigmentation, to book an appointment or get a referral to see your board certified or Royal College certified dermatologist, because really that is our role, is really to find the best treatment regimen that will work for you.
Yeah, I'd really like to echo that. And I'll definitely be integrating some of your tips and tricks and strategies into my own practice. And thanks everyone for joining.
Thank you.
Thank you to Drs. Miller-Monthrope and Richer for their knowledge and expertise. Join us on August 21st, 2021 for the conclusion of the Summer of Dialogue series, our live colloquium on black skin. The Skin Spectrum podcast is produced from studios in Buffalo, New York and Toronto, Canada by Chronicle Companies, publishers of the Chronicle of Skin and Allergy and organizers of the Skin Spectrum Summit. Visit us at www.skinspectrum.ca or www.derm.city, where dermatology lives. We would like to thank our in-kind partners. At the Nurse Practitioners Association of Ontario, the Canadian Association of Aesthetic Medicine, and the Primary Care Dermatology Society of Canada. Subscribe to the Skin Spectrum podcast at Apple iTunes, Google Podcasts, Stitcher, Spotify, or wherever you get your podcasts. This episode was produced by Jeremy Visser with assistance by Aria Impakaris. Research was done by Kylie Ravernick and Catherine Brenders. Until next time, thanks for listening. We'll see you again next week.